Get ready to take a flamethrower to the official narrative and learn what the elites don't want you to know. You're listening to The Tom Woods Show.
Hi, everybody. Tom Woods here. It is episode 2573 of The Tom Woods Show. And unfortunately, for your aesthetic pleasure, you do not have my normal backdrop of books and various scholarly items, because I am broadcasting to you today, as I record this episode, from Buenos Aires. Here, I'm spending the week in Argentina, but I wanted to get this episode recorded. So I brought my equipment with me, because I'm very glad to be joined by Dr. Jonathan Shedler, whom I've started to follow on on the social media platform formerly known as Twitter, because he reminds me of myself in some ways, in that he's scholarly, but he doesn't take any BS from anybody, and he can be bellicose in ways that are entertaining and intellectually fruitful. He's at the University of California at San Francisco. I'll see in a minute how you feel about that characterization, but let me just tell a little bit about your background. Dr. Shedler is best known for his article, The Efficacy of Psychodynamic Psychotherapy, which won worldwide acclaim for establishing psychoanalytic therapy as an evidence-based treatment. He's author of more than 100 scientific and scholarly articles, creator of the Shedler Weston Assessment Procedure for Personality Diagnosis and Clinical Case Formulation, and co-author of the Psychodynamic Diagnostic Manual. There is a lot of pop psychology, let's say, out there that drives Dr. Shedler up a wall, and I want to talk to him about that and other things. So, Dr. Shedler, what do you think about that?
I think your last statement is pretty accurate.
Okay. All right. Well, that's my official introduction of you. I got to know you, I think, because my wife started following you, and she said, you would really, really like this guy. And I'll just tell you something a little bit about probably the majority of people who listen to me would agree with you when you say there are some people in my field or adjacent fields who are bringing ideology into their professional work, which is profoundly unprofessional, or they are cheapening what is a genuine science by reducing it to pat slogans and platitudes. And they would agree with you on that. But they would tend to go, I think, to the other side and say, the whole field is a whole lot of pseudoscientific nonsense. Nobody needs therapy. It's a whole lot of nonsense about coping with trauma. Well, if you obsess over it all the time in therapeutic settings, of course it's going to be haunting you. You got to just toughen up and move on. I want to address that, because I want to know, because I do see in my circles people speaking more or less that way. So at its best, tell me what the kind of therapy you do at its best can do for someone.
Okay. I want to just hit one thing right off, which is, it's subtle, but it happened very quickly. This equation of what happens in therapy with obsessing or ruminating, right? So that's an assumption that I think you're repeating, an assumption out of the starting gate, as if the only alternatives we have are, to toughen up and ignore things and push on, right? Ignore the difficulty, or to obsess and ruminate about them. And one of the things that happens in what I'm going to call real psychotherapy or meaningful psychotherapy, because there's a lot of stuff going on that's called therapy that I don't think is legitimate psychotherapy. One of the things that happens is that we create choices and options that aren't initially evident or apparent, right? So when we say, well, the choice is to toughen up and, move on, or obsess and ruminate, that's a false dichotomy. And real therapy would help a person to recognize that there's alternatives to that.
So let me take an example.
I got so caught up in obsessing and ruminating. Now I lost track of what was the question, but that was.
Well, how would you persuade somebody who is so unimpressed by, let's say, the pop Facebook version of what they think therapy is, that they go to the conclusion that it's all bunk and not necessary and nobody really needs it. And we're all doing too much therapy and it's not doing any good.
So I have profoundly mixed feelings about that, because I hear people say that a lot. And the mixed feelings are based on what a lot of people are seeing and what's represented as therapy, in public and social media. I don't blame them one bit for coming to those conclusions, right? There's a lot of hokey pop culture nonsense that's pretending to be about psychology and psychotherapy. So I understand where that point of view comes from. On the other hand, what they're seeing, what they're responding to, what they think is therapy has almost nothing to do with legitimate psychotherapy. And, unfortunately, for a variety of reasons that we could talk about if it's of interest, the mental health professions have been in free fall for more than 20 years, 20, 25 years. There is no universally agreed upon thing anymore called therapy. There is no universal standard for what it means for somebody to call themselves a therapist. Therapist is actually not the name of a profession, right? There is no consensual, shared curriculum in terms of training and education that people who call themselves therapists get. It's the Wild West out there. And what we have now, unfortunately, and it breaks my heart to have to say this, is that the field is just glutted with people of all kinds of different background and training who call themselves therapists, who really have very, very minimal training or understanding or skill. De facto, the therapy professions are not regulated in a meaningful way. I mean, it would, right? So what most people encounter in public spaces, and including and especially in social media, encounter that's called psychology or psychotherapy is, to me, kind of a bad joke.
What would be a quick example of the difference between how somebody like you would handle a particular problem and the way one of the people you're deriding would, quote unquote, handle it?
One of the things that serious psychotherapists understand is that there's a difference between the problems on the surface that bring somebody to therapy, right? Somebody comes in and says, I'm depressed, or I'm anxious, or, my eating is out of control, or I'm having panic attacks, or whatever it is, right? And the underlying psychological issues that are driving that or creating the vulnerability to the problems. So, we could talk about problems that are upstream and problems that are downstream, right? This is a bit of a generalization, but it's true far more often than not. The most common diagnosis recorded in the United States and North America is some form of depression. Depression is an effect, not a cause, right? It's downstream from something else. So a real psychotherapist, somebody who's genuinely skilled and genuinely well-trained, we're not in the business of treating depression, right? Because it's an effect. We're in the business of figuring out what's going on psychologically, right? Upstream from the depression, right? That's coming out downstream, right? In the form of what we call depression. So we can make a distinction between what you see on the surface of things and the underlying psychological processes that are giving rise to them. And, we could say there's, two kinds of people in the field who are practicing psychotherapy, or what they call psychotherapy. Those who think that the problem that you see on the surface is the problem, and those who understand that there's something upstream from that problem, and that's really the focus of our attention if we're doing serious work in psychotherapy. And what I mean by serious work in psychotherapy is ultimately we're trying to change something about the person, right? Who they are and who they function in the world, right? Not just this or that symptom or behavior that they have, but right, something about who we are as people, right? To become a better and freer and more whole version of ourselves, right? That doesn't have to be vulnerable to the kinds of symptoms that show up and get often get identified in treatment as the problem.
Did you always doubt the chemical imbalance explanation for depression?
I'm not sure any critical thinking, serious scholar or scientist ever took that seriously. First of all, right, yes, I always doubted it, but so did damn near everybody else that I respected. This idea of a chemical imbalance was this is not a scientific finding. This is not a clinical discovery. I mean, truth be told, this was a marketing campaign by pharmaceutical companies selling medication. And these marketing campaigns, these narratives, were extraordinarily successful. Right? And they succeeded in convincing vast numbers of people that depression, right, is a chemical imbalance. Even in the heyday of, when people were saying that, which would be like the early 1990s, very, very few people, including in psychiatry, ever took that seriously. I mean, at this point, it's been completely debunked. Now let me make a clarification. That doesn't mean that antidepressant medications aren't helpful for some people sometime. What it means is, however they operate, whatever they do that is helpful for people, that's not the mechanism. Nobody even knows what chemical imbalance means other than as a marketing slogan.
Hey everybody, let's take a minute to thank our sponsor, Persist SEO. If you're getting buried by your competition online, then build your brand, your reputation, and your lead flow with digital marketing by Persist SEO. If you're a small local business trying to compete against large companies in the service industry, then increase your visibility with Persist SEO. What if you have low or no leads coming in on a consistent basis? Well, then website search engine and conversion optimization can help move the needle to a more prosperous business model for you. Are you tired of cold calling and networking? Use your website as a lead generation engine. What if you're not showing up for your services in the search engines? Well, get found with Persist SEO Expert Search Engine Optimization. All you have to do is call 770-580-3736 or visit them at ineedseo.help for a free website audit and consultation. That's 770-580-3736 or ineedseo.help. I've known quite a few people who at one time or another in their lives have described themselves as having depression. And they look at depression as being a freestanding thing that has hit them, that leads them to, that makes it difficult for them to do basic things. They feel overwhelmed by inertia, hopelessness, so that even performing basic acts of ordinary hygiene can seem insurmountable.
And that's a very common way. People experience it just the way you described a lot. but you added something, you prefaced it with something else. And you said, it's a freestanding thing. It's like they've come down with a case of depression,
Right.
the way somebody might, come down with, influenza or COVID or Ebola, right? That's where there's some slippage. So, we have to understand, this goes back to what I said earlier, that depression is downstream. There is no single unitary thing called depression, right? It's not like having a bacterial infection or influenza or diabetes. It's not one thing, right? It's sort of the final terminal outcome or result of quite a lot of very different underlying difficulties. So the way I think it's more helpful to think about it, and the way I teach it to my own students, is if we're going to use a medical analogy, and think about it in terms of symptoms and diseases, I think it's much more helpful to understand depression as a non-specific symptom like fever. Okay, so medically, what is fever? What is the definition of fever? It's a non-specific physiological symptom that can be caused by an enormous range of underlying medical conditions, right? They all cause fever. So if you have fever, the underlying condition could be anything from, the common cold to Ebola. Fever is a symptom, a physiological symptom. Depression, I think, is best thought of as the psychic equivalent of fever. It's a non-specific symptom of an enormous range of underlying difficulties. And what a serious, skilled mental health practitioner does, right, is try to understand and address the underlying difficulties.
Now, it's interesting you say that. I already knew that was the way you thought, but one of the complaints some people have about modern medicine, let's say, is that they feel like it's just symptom management. We'll try to suppress the symptoms, we'll try to alleviate your pain, but they feel like a lot of what's done in the medical setting doesn't really ever get to the real root of the problem, doesn't really cure it. But it sounds like what you're saying is that in the approach you take to depression, you really are you're not just managing the symptoms,
yes,
quote unquote. You really are trying to get to the heart of what is causing this. So how do you, presumably you can explain for the layman, if somebody comes into you saying, I'm suffering from depression, what is the process that you follow to try to get to the heart of where this is coming from?
Well, it depends. A lot depends, right? Because again, if depression is a symptom, right, and not a cause, right, then we get in the business of, investigating possible causes. And as we investigate, it might take us down quite a lot of different pathways. So there isn't a universal answer. I do want to say that the complaint that you're echoing, that's about managing symptoms and not dealing with the actual underlying problem. Unfortunately, that's often true. Right? I mean, what we've done is we've tried, I say we, a lot of this goes back to the economic interests of health insurers and pharmaceutical companies. We've tried to shoehorn psychological difficulties into a medical treatment model and act as right. And what we're doing really when we try to manage the symptoms, often, this is a generalization, but often we're providing people with first aid, something to help them feel better in the relative short run, but not actual, right? In medicine, everybody knows the difference between, what's first aid, and what's medical treatment for the real condition. In mental health, it's like those things have gotten very, very blurred, and people are given first aid and told that they're getting treatment. So I think actually the criticism is very valid.
I think the popular understanding is that the difference between a psychologist and a psychiatrist is that the psychiatrist can prescribe drugs. Is there a profounder difference between these two fields than that?
Yeah. I mean, first of all, things have been in flux. In the old days, like a generation ago, most psychiatrists provided psychotherapy. Right? And many of them became very highly skilled psychotherapists. There were very major differences in training, the pathways to get there. Right? Psychiatrists are MDs and are trained as, and have medical background. Psychologists were PhDs, or now PSY, Doctor of Psychology degrees. Anyway, they have doctoral level academic training. So they're really very different pathways, right? Psychologists weren't medical doctors. They didn't prescribe medication, right? But really there was quite a different trajectory that led to becoming treatment providers. Because of economic changes over the last generation, driven largely by the pharmaceutical and the health insurance industries, relatively few psychiatrists practice meaningful psychotherapy anymore, right? A lot of psychiatrists, many would deny this or want to argue but it's just empirically a fact. I mean, relatively few psychiatrists these days provide much in the way of psychotherapy. Many of them are, almost entirely in the business of prescribing medication.
Now, when you say that there's no universally agreed upon standard for what constitutes a therapist, is the problem that some people are posing as therapists without the proper credentials? Or is it that even the proper credentials these days don't necessarily indicate that the person is prepared to do what a psychotherapist should be doing?
Yes to both. So one thing that it's important for people to understand that people don't understand, people will use words like psychologist and therapist or psychotherapist interchangeably. They're not interchangeable. A psychologist has a doctoral degree, has to meet pretty stringent training requirements and be licensed as a psychologist. The word therapist actually has no professional meaning. It's not a credential. It's not a protected title. It's not the name of a profession. So what we have are many, many different professions, all of whom and people in all of these different professions practice therapy and call themselves therapists. And if that's all you know about the person, you know less than nothing about their training and background. So I took an interest in this because of something that happened on Twitter. But I started looking at different kinds of licenses, and they're all signified or denoted, somebody's name followed by a collection of a collection of letters, and I found something like 65 different kinds of credentials across 50 states. And then I just got bored and stopped looking. So more than 65 of different kinds of credentials and professions that authorize people to provide psychotherapy. The most common ones are PhD and PsyD psychologists, licensed clinical social workers, LCSWs, licensed marriage and family therapists, licensed professional counselors, dozens and dozens and dozens of variations thereof, And not only, and the differences in training are just vast. And even with that mess going on, in most states in the United States, a therapist doesn't mean anything. Anyone can hang up a shingle and call themselves a therapist without any degree, without any license, without meeting any credentials. I don't know what state you're in, but the overwhelming likelihood is you could hang up a shingle tomorrow and call yourself a therapist, right? And that's bad enough. The real tragedy to me is most people, the public, people who might be in need of mental health care, don't know this. They go to someone who's identified as a therapist, and God knows what they're getting by way of so-called treatment.
Hey, everybody, this is not a sponsor message. I just wanted to remind you, first of all, that my Christmas party is coming up December 7th. It's about 35 minutes southeast of the Orlando airport, and it's a wonderful time. A chef prepares dinner for everybody in our own kitchen. I have several minor celebrities who are going to be coming, and it's just a wonderful night to get to know a lot of really great people. You can be yourself. You don't have to watch what you say. And everybody raves about it. So I hope you can attend. It's a benefit enjoyed by members of my Supporting Listeners program. Now, I have supported people on Patreon in the past, and I've been very happy to do so. But supportinglisteners.com beats the heck out of any Patreon you've ever contributed to. Because how many of those people are inviting you to a Christmas party? Or how many, instead of having you look at a godforsaken screen 24 hours a day for their content, are also mailing you in the physical mail a print newsletter like this one? Like this one's 16 pages. This one's 20 pages. You get that in the physical mail, and it's not just the same things I send in my email newsletter. It's all fresh content, not seen anywhere else, just for you, nice and hot. So for a change, you can be old school. Remember, we were old school, right? We liked reading physical things. Well, ain't no podcaster or any Patreon sending you a physical newsletter, or for that matter, inviting you to a murder mystery dinner party for free. I have several of them lined up for around the country with many more to come. The one in New Orleans still has plenty of spots available, and you can pay to attend these murder mystery dinner parties, but you don't have to. Just be a supporting listener of the Tom Woods Show. You get that for free. Not to mention my censorship-free Tom Woods Show elite group. It is the best possible supporters program in the world, and you're part of a community that you just can't beat. So check it out at supportinglisteners.com, and before you know it, you will be holding in your hands one of these right here. Supportinglisteners.com, and thank you very much. Now, you use a provocative term to refer to what it is that you do. You say that it's evidence-based. Now, we would like to think that everything in science is evidence-based. So why do you feel the need to point out that it's evidence-based,
Okay.
and what kind of evidence are we talking about?
Yeah, so it's not my term at all. I actually have some real issues with the term. Let me zoom out for a moment and give you the context. So the term evidence-based actually comes from medicine, not psychotherapy or mental health. It gained traction in the 1990s, and really it was a call in, right, because medicine was a very orthodox kind of profession. There were sort of ways of doing things, and you learned to do things the way your teachers did them, who learned it from their teachers, etc. Originally, evidence-based medicine was a call for critical thinking in medicine, and the intent of those who initially promoted evidence-based medicine was that treatment decisions shouldn't just be made because that's the way we've always done it, but they should reflect, number one, the best available evidence, scientific evidence from empirical research. Number two, the clinical judgment and knowledge and hopefully wisdom of the physician or the healthcare provider. And number three, the needs and values and preferences of the patient. So you could think of it as a Venn diagram where those three elements would overlap, right? Empirical evidence, clinical skill and experience, patient desires and preferences, and evidence-based medicine was supposed to be the intersection of those things. The term then got picked up and adopted in psychology, came to mean something de facto a little bit different. Typically, when people refer to evidence-based therapy, it refers to therapies, modalities of therapy that have been studied in a randomized control trial. So basically the same kind of research design that's used for medication trials, right? Where people are randomly assigned to a treatment group who gets, the treatment of interest, and some kind of comparison control group that doesn't get the treatment, right? So when somebody says evidence-based therapy, it means that there have been randomized control trials demonstrating that the treatment is more effective than a control group. I'm going to say a lot about this because the term, at least as applied to psychotherapy, has really morphed into a marketing buzzword. And right, so when I think the layperson, or actually even a lot, not just lay people, also a lot of clinical practitioners, they hear the term evidence-based therapy, and what they think it means is we have scientific evidence that people get meaningfully better. That's actually not what it means. It's basically become a kind of branding for a certain kind of branding for a very particular model and approach within therapy that actually isn't, right? Like actually doesn't work for most people most of the time. But that's a whole other issue. I'm not sure you wanted to get into that issue.
Well, I guess I want to know, are we measuring how many people come to see you reporting a problem ranging all the way up to the absolutely debilitating, and then after some reasonable length of time report no longer having that problem? I assume that's the primary thing we're measuring.
No, actually it's not. Right. So that's the issue. That's why I'm saying it's a marketing buzzword. What you just said is the right question, right? This is what, right, patients and prospective patients and clinicians really need to know, right? If somebody gets this kind of therapy, do they get better, right? And of course, we need to ask the question in a more nuanced way. What percentage of people who get this therapy get better? How many? Right? How much better do they get? Right? But those are the clinically meaningful questions. What we've got is a whole research industry, and it's been going on for 40 plus years, where people are actually answering a very different question. Researchers are answering a different question and pretending that they're answering the question you just asked. The question they're really asking is there scientific evidence that people who get a particular form of treatment are better off on average than a control group that does not get treatment, or at least does not get treatment that's legitimately intended to help? That's a very different question, right? Let me just unpack it a bit. Nobody goes to treatment because they want to do better than some untreated control group. People go to treatment because they want to get well, or at least meaningfully better, right? So those are different questions. And we've got people out there promoting various forms of psychotherapy, and they're advertised, promoted, marketed as evidence-based therapy. And people think it means, well, if I get this treatment, the overwhelming likelihood is I get well. And actually what it means is, well, people who got this treatment did marginally better than a control group that got no real treatment. Right? There's a kind of a sleight of hand that goes on. So let me just simplify this and boil this down a little bit to something practical. We're selling a myth that you can identify a brand name of therapy. You should get this brand of therapy: cognitive behavior therapy, interpersonal therapy, psychodynamic therapy, DBT, and right, as if you were choosing different kinds of medications or medical treatments. And that if you get this brand of treatment, what you're getting is something that's uniform, right? If you get this treatment, you're getting the same as somebody else who's getting a treatment with that same name, right? And that what matters is the treatment brand, right? So we're selling this myth that people should choose a treatment brand or a treatment modality. Actually, what they should choose is the best, highest trained, most experienced clinician, individual therapist they can find. It's not the brand. It's the skill and the expertise of the individual clinician. So when somebody says, here's what's going on, I'm depressed or whatever, what kind of treatment is right for me? My advice is you're asking the wrong question. The right question is, how can you find the best clinician?
Psychotherapy consists of, I come visit you, I talk to you about what I perceive my problem to be, and you, over the course of a series of sessions, help me overcome it. More or less true?
Yeah, in broad strokes.
Okay. So you may well diagnose me with a condition. You may say, I see what you have. You have this particular disorder that we've identified in the book. And once you've done that, I'm just curious as a layman. I know you could give a whole weekend conference for this answer, but as a layman, I'm curious to know, once you've reached a reasonable level of confidence in a diagnosis, and given that your profession does not involve physical therapy, it doesn't involve injecting me with anything, there isn't like a list of A, B, C, do these physical things, how does the diagnosis affect the kind of conversations you have with me?
For most of the things that we can treat effectively in psychotherapy, the diagnosis from the DSM, right, the Diagnostic and Statistical Manual of Mental Disorders, sometimes called the Bible of Psychiatry. For most of the things that we can effectively treat in psychotherapy, a DSM diagnosis is pretty irrelevant. For the reason I said at the beginning, right, DSM is a classification not of causes, right, not of upstream causes, but of downstream effects and symptoms. So when I diagnose major depression or generalized anxiety disorder or panic attack disorder or whatever it is, all I've really done is, come up with a generally accepted nomenclature to use,
right,
to describe, the surface of the symptoms that you're having. It tells us nothing about the causes of those symptoms or the kind of treatment that would be effective for you, right? Any more than diagnosing that you have a fever is adequate information to know what's wrong and how to treat you. I mean, I can do some short, right? If I were a physician, you can do some short thing, some like first aid kind of things in the short run to help reduce your fever. Like, you have fever, take aspirin, right? But right, that's just managing the surface symptom. It's not treating the medical condition that's causing it. So one of the things that we have to know when somebody comes in with, depression is, is this, a relatively not serious, reaction to something that's likely to resolve on its own. It doesn't really need therapy, right? Right? Is it caused by something that we can address relatively quickly in psychotherapy? Is it caused by something that's really baked in to who you are as a person and how you function in the world? In which case, depending on what that's about, right? That gives us a different treatment focus, right? In which case, meaningful psychological change is going to take a while. Right? We have a lot of, let's say, stakeholders in the mental health business who have an investment in selling a fiction that we can treat long-standing, deeply ingrained conditions, in a matter of weeks. Simply. What we're actually talking about, though, for most people, most of the time, by the time somebody right, it's not like somebody, wakes up with a case of depression on Monday and calls a therapist on Tuesday. That's not how it works, right? That by the time somebody gets to a psychotherapist, more often than not, it's a long-standing problem. They've struggled with it for a long time. They've tried quite a lot of things already, right? To try to get through it or get over it. And more often than not, it's really woven into the fabric of who they are as a person, right? And that's, right, if it's serious psychotherapy, that's what we're really trying to address, right? Not what condition you have, right? What did you catch? What disorder did you come down with, right? Not who you have, but something about who you are. It's very different.
This is a poor analogy, but if we're talking about physical therapy, like I get into an accident and I hurt my legs, I go to a physical therapist, my legs get stronger, and eventually I return to normal life. Now with psychotherapy, or let's include quote unquote therapy in general, a lot of times, you're right that of course we can't know the same way we can know with legs. I can estimate within 6 months your legs will be better. If somebody comes in to see you with depression, you can't say in 6 months you'll walk out of here feeling great. But presumably the point of this is, as you say, for the person to feel considerably better or even not to have the disorder anymore.
Of course.
But we laymen, see a lot of people who wind up in quote unquote therapy that becomes, the therapy itself becomes like a self-justifying goal with no end in sight. I've been going to my therapist for 10 years.
But then something has gone wrong, because therapy, meaningful therapy, is supposed to have a goal and a purpose and a focus. So I literally never do therapy for the sake of doing therapy. I teach my students, we don't do therapy for the sake of doing therapy, right? Meaningful therapy begins with a mutual shared understanding about what is the purpose of this work? What are we trying to accomplish here together, right? It should have a beginning and a middle and an end based on that purpose. Now, things are a little more complicated with therapy because you and the patient might develop a shared focus, an understanding of, what is it that we're here to do? What's our purpose together? And as the treatment unfolds and you start to learn more and you start to understand, right? The patient starts to understand more about themselves, and you, the therapist, start to understand more about the patient, right? That purpose might evolve, right? It's not static, it's dynamic. It might change as treatment is going, but there's always a purpose, right? So in order to start therapy, I'm going to speak to you at a fairly high level, and I have the impression that your listeners, are people who are thinking and understanding at a fairly high level. So, I'm going to tell you this the way I would tell a graduate student or a psychiatry resident. First of all, these are the conditions necessary for doing psychotherapy. The purpose of the work is to help the person change something about themselves that's causing unnecessary suffering or limitation, number one, that the person desires to change about themselves, number two, and that's realistically possible to help change through the work of psychotherapy. So when somebody comes in, a prospective patient, for an initial meeting, I'm not starting therapy, right? The first meeting, or meetings plural, the purpose of those meetings is to basically to do something that's analogous to a medical examination, to figure out, to develop an understanding of what's wrong and what's going on psychologically that's leading to these problems, right? And to offer a consultation to the person about, number one, where's the action here, right? Like, what is the thing about you as a person that's causing difficulties or getting in your own way? And do we have can we develop a shared understanding? Can we see that the same way? Number two, right, is it something that troubles you enough that you want to try to change about yourself? Number three, is it something that psychotherapy could realistically accomplish? Right? So it was a consultation to determine whether we can answer those three questions in a satisfactory way. And if the answer is no, if we can't answer those questions, I don't proceed with therapy for the sake of doing therapy. I don't make a recommendation for the person to begin therapy. Right? Those are the conditions under which I proceed with therapy. I would suggest, there's different kinds of therapy that have different purposes, but the kind of psychotherapy I'm talking about, the aimed at meaningful, lasting psychological change, right? If those conditions aren't in place, it's not going to be effective. So that might be a longer answer than you are.
No, that's a great answer. That's a great answer. And in fact, I like very much something that I found on your Twitter feed not that long ago, maybe within the last week or so. And you said, ultimately, there are basic truths of human psychology most people understand intuitively. One, we do not fully know ourselves. Two, the things we don't know can cause suffering. Three, there is benefit in self-knowledge. That seems pretty uncontroversial.
You would think. But it turns out it's very controversial inside and outside of the mental health professions. See, because behind those three statements, right, when you say we don't fully know ourselves, right, behind that statement is an understanding, right, that consciousness isn't all there is. What we're consciously aware of, what we know about ourselves, what we can tell about ourselves for the asking, right, is only, a small subset of mental life, right, of what's going on internally. So we say we don't know ourselves, saying, a lot of things happen outside of awareness, outside of consciousness. This ties back to what I said at the beginning about, there's a presenting problem, like the thing the person is aware of that's, causing suffering, like anxiety or depression. There's something upstream from that that's causing the vulnerability to anxiety or depression. What's upstream is very often something that the person doesn't initially know about themselves. Right? That's why we do this consultation, right? To try to figure out what is going on, right? That is driving or fueling these problems. And you say, here's a big dividing line between what I would call serious psychotherapists and, therapists in air quotes, pop psychology, social media therapists, is recognizing.
In fact, even when it's not related to a mental health problem, on those occasions, for those people who do lead an examined life, on those occasions, when you do make a discovery about yourself, it's very illuminating and jarring to realize that there is something about you that only through great effort did you yourself manage to uncover. I mean, these are great things to do, even when they're not directly related to our mental health. It's great to examine yourself and make discoveries that maybe other people knew better than you somehow.
Well, it is. And this is also part of the essence of psychotherapy, that the things that we don't know about ourselves generally show up in one way or another, or manifested in our relationships with other people, right? So there's, we could say that there's the things that we know about ourselves that we consciously are aware of and understand. There are things that we don't necessarily know about ourselves that we live out, that we enact with other people in our lives in one way or another. And this is the essence of the kind of psychotherapy that I'm describing today and that I practice. So, right, our psychological difficulties play out, and especially the ones that we don't fully understand ourselves, play out in the context of our relationships. Psychotherapy is also a relationship. Real psychotherapy is a relationship. It's a meaningful relationship, right? So we go through life, looking at and experiencing our relationships through certain lenses that are formed early on in our lives, right? We bring those lenses with us into relationships we enter, and therefore we tend to recreate the same kinds of patterns in our relationships, for better or worse, right? If the patterns are patterns that cause suffering or limitation, right, then you might end up in psychotherapy. But anyway, we all do this. It's not about health versus psychopathology. It's about the human condition. We repeat and recreate certain kinds of life and relationship patterns. When we go into therapy, we bring those lenses, those patterns with us into this new relationship, and we begin to recreate our patterns in this new relationship with this new person, the therapist. And this is how the patient and the therapist together can begin to learn about the aspect of the person's internal world, their psychology, that they didn't previously have access to. They weren't consciously aware of, because they're being lived out in the therapy relationship. The difference between the therapy relationship and all other relationships that we have in our life is that in our other relationships, we just repeat and live out our patterns. In psychotherapy, if things go well, hopefully we don't just repeat them with a new person. We develop a way.
I hate to pollute our otherwise fine conversation with this, but I can't not bring this up before wrapping up with you. You can find, without too much effort, on social media, people, and I don't know if these are professionals, amateurs, laymen, whatever, but I think some of them were professionals, saying that men who voted for Trump need therapy. Now, do you believe that do you feel like, obviously, a statement like that is just a disgrace to the profession?
I don't even understand how it fits with, my understanding, what I just explained about what therapy does and how it works, right? I mean, I don't know what it means to say somebody needs therapy. So at the risk of repeating myself redundantly, right? The goal of therapy is to change something about ourselves that is causing suffering or limitations for us that we desire to change about ourselves, and that psychotherapy could realistically help us to change. For somebody to make a statement in public, especially, especially speaking, as a professional, and say, if you do this, anything, fill in the blank, voting is, one thing. If you do this thing, if you think or believe this or that thing, then you need therapy. It just doesn't even fit with my understanding of what psychotherapy is. So, yeah, these are troubling. These are troubling comments that you see online.
Well, if it makes you feel any better, I feel like my profession of history is having a bunch of problems. Economics having a bunch of problems. It's like everybody, just when you think, oh boy, my field is uniquely screwed up, then you have an interdisciplinary meeting and you say, well, I don't know if I feel better or worse to know everybody feels this way about this field.
We have some cultural issues going on.
Well, no doubt about that. And I think it was you who commented on the so-called replication crisis and said, this is, correct me if I'm wrong, but this is not a problem unique to psychology. It's that these are the easiest studies to try to replicate. But if you did this in the hard sciences, you'd find a lot of the same problems, which indeed they have.
It was me. I did say it. Other people have said it too. It's not like this is my unique. It's not if you did these studies in the hard sciences. It's been done. Right?
Yeah.
I mean, it's really unfortunate that this whole issue of replication in science got attached to psychology and stuck. Right? I mean, what really happened? There's a guy named John Ioannidis.
From Stanford.
Yes. And he wrote a pretty serious paper doing some serious critical thinking and statistical, probabilistic reasoning about publication in science, not in psychology, in science. And for various reasons, and it's a pretty elaborate and carefully reasoned paper, he came to the conclusion that most published findings in science are probably false. Right? So this was deductive and logical and mathematical reasoning. At some point, somewhere along the line, and I'm not sure the history of how it came about, but funding became available to put this to a test. And, because it was low-hanging fruit, it's a lot easier to duplicate, to replicate a typical experiment in social psychology than it is in cancer research or heart disease research. They started with psychology, right? And tried to replicate some well-known studies and found that it was really a struggle to replicate them. And, an alarming number of studies didn't replicate. Now, that same kind of research has been done with respect to cancer research, heart disease research, other areas of research. This is a replication problem in science. And there's a reason for it. I mean, it's because of the incentive structure of how the academic research world is organized. And there's something baked into research methods, the statistical research methods that we rely on. Anyway, there is something in the scientific enterprise itself, right, that should raise questions for people who, are concerned with thinking and understanding scientifically. It's not a replication problem in psychology.
Right. And I initially got that wrong, I myself, but then I corrected myself when I realized, no. This is, they would like us to think that, because then that takes the heat off everybody else. It's just these people over here. No, it isn't. It's a major problem. First, I do want to make a quick apology. As a lot of people know, in many hotel room settings, there's inadequate lighting. And since night has fallen, since you and I started this conversation, I've gotten darker and darker as the conversation has gone on. So I apologize that the video quality is not what everybody has come to expect from the Tom Woods Show, but I hope that the intellectual quality has been of the usual caliber. So Dr. Jonathan Shedler, I want to thank you for the conversation. The website is jonathanshedler.com. Follow him on Twitter at Jonathan Shedler. If you have a final word, we'd certainly be delighted to hear it. And it has to be extremely profound. It's a final word.
No pressure here whatsoever. I'll just finish a thought. I don't know if it's a final word about anything final, but I'll just finish a thought that I started before, because I think it's people who are interested in how psychotherapy works. I think it's really the essence of something. I was saying we all live out certain patterns in our relationships and view relationships through certain lenses, right? We live out patterns throughout our lives. It's not pathology, it's human nature. But the way the kind of therapy I'm describing works is, first of all, it's a relationship. You need to meet with the same person on a regular, sustained, consistent basis over a meaningful period of time. It has to be a real relationship. You, the patient, bring those lenses and patterns into the therapy relationship where they get lived out with a new person. The difference between every other relationship in our lives and psychotherapy is in every other relationship, we just live out our patterns, for better or worse. In psychotherapy, we start paying attention to them, noticing them, describing them, attaching words to them, and so becoming increasingly aware of them. And out of that awareness comes freedom, right? The freedom to not have to spend the rest of your life reliving and repeating the same patterns, the freedom to be able to do things differently. And that is the essence of psychoanalytic psychotherapy.
Now you see, I'm very glad I asked you for that final word. Very well done. Thank you very much, Dr. Shedler. I appreciate it.
My pleasure, and I appreciate that you made time to do this all the way from Argentina.
That's how much I want to. And I know I was supposed to be calling you Jonathan. I just can't resist it. Thanks so much again, and thank you, ladies and gentlemen.
Make yourself and those you love less vulnerable to the regime, both mentally and physically. Get more forbidden information at tomsfreebooks.com and be sure to subscribe to the show wherever you listen. See you next time.
Like the sound of The Tom Woods Show? My audio production is provided by Podsworth Media. Check them out at podsworth.com.